All right, so cirrhosis has a lot of complications, like I said. The liver has how many functions again? Over 500. So you're going to have 500 symptoms, 500 complications, and 500 medication if you know for the test for Monday. I'm joking. So those are really the ones we have to focus on. And those are the big ones, and they are life-threatening. We have to recognize what they look like, what the treatment is for each one, and what kind of teaching we might teach each one, right? So if someone has hepatic encephalopathy, how do I avoid this in the future, right? If they have hepatocellular carcinoma, they got to look out for these symptoms, right? And the symptoms are usually vague, just like most cancers, but you're going to teach them to get routine screening, as we'll come to find out. It's usually ultrasound. And also, what other lab tests do we mention? AFP, which is alpha fetoprotein, that can assess if you have liver cancer developing. Okay, so again, we have a liver normal right here that's become cirrhotic, and cirrhotic means what? Means scarred. All right, so it's a very scarred liver and sclerosed. Okay. All right, so there's examples of some of the symptoms at the top left there, but there's a lot of different symptoms that could just be associated with cirrhosis, right, including jaundice. So we already have those in our tool bank, right? They have jaundice-like symptoms. High bili symptoms, right? So their T-bili will be elevated. They'll have pruritus. They'll have jaundice. They'll have icteric sclera. But what else do they have? Because the liver has so many functions. All right. So overview. So it's an irreversible process. Once you become cirrhotic and scarred, it's usually irreversible. You can't reverse that. There are some medications nowadays that can halt the progress of it, but usually once it is cirrhotic, it's really hard to reverse it, right? And 35,000 people die annually from this, and it's usually age 25 to 34 if they're alcoholic. Otherwise, they die in their 50s because it takes 20, 30 years for Hep B, C to develop into cirrhosis, right? You can have alcoholic cirrhosis, right? You have alcoholic hepatitis and alcoholic cirrhosis. One is because they drank too much, right? And they have a liver inflammation, and one is they drank every day for 20 years, and now they have chronic inflammation of the liver, leading to liver cirrhosis, right? So alcoholic cirrhosis is about 50% of our known causes of cirrhosis. And then Hep B, C, we mentioned those can progress to chronic disease states such as cirrhosis, right? So it's about 30% are Hep B, 10% are Hep C, right? And we've got NASH is on the rise. So NASH is non-alcoholic. So it's not alcoholic fatty liver. It's a non-alcoholic fatty liver. And that is inflammation from all that obese fatty tissue. There can be repeated biliary disease. We'll talk about biliary later. There can be genetic issues we mentioned before as well. They lead to cirrhosis, buildup of copper, which is genetic, buildup of iron, which can be genetic, but also can be due to like multiple blood transfusions and such. And then poor blood flow is something you would see more in the ICU, where they have chronic shock states, chronic low blood pressure, but also CHF, right? When you have CHF, you have left-sided heart failure and right-sided heart failure. When you have right heart failure, what are the symptoms you get? You get JVD, edema, and what else? For right-sided CHF, you get hepatosplenomegaly, right? So you get hepatomegaly, your liver gets big. When your liver is big and full of fluid, you think it works good? No, it's inflamed. So you can get what's called cardiac cirrhosis from that. Okay, and same thing, the kidneys are not getting as forward blood flow, right? Because the heart's not working, or there might be something else that's making the blood volume reduced, and you can lead to kidney failure. When you get kidney failure, you get to fluid volume overload. You get fluid volume overload that leads to CHF. You get to CHF that leads to hepatorenal syndrome and to cardiac cirrhosis. It's all interconnected. All right. So a lot of these are recaps. We got drug-induced. We have alcohol-induced. You have hepatitis we talked about, and then all of these are leading to cirrhotic changes, right? Again, it takes about 20, 30 years for hepatitis and also 20, 30 years of chronic alcoholism to cause this damage. All right, so causing liver cirrhosis. And we'll talk about a lot of these complications, especially portal hypertension. That's usually the crux of most of the problems. So again, there's 500 vital functions there. A lot of those functions are to detoxify. One of the things they detoxify are drugs, but also they detoxify excess amino acids. And the amino acids get broken down into urea, right? If that process fails, you build up ammonia, right? So ammonia usually gets built up in liver cirrhosis, and we'll talk about that consequence. That's called hepatic encephalopathy, right? So that's one of the big complications we'll talk about. Portal hypertension is due to the sclerosing factor, not so much the functions failing, but some of the functions failing, right? We can't produce protein, right? So one of the proteins that are important is albumin. So albumin is a protein that holds on to water in the bloodstream. So the water is not being, sorry, you have low albumin, then you have low volume circulating around. And who doesn't like low volume? The kidneys don't, right? So that's one of the reasons why you get hepatorenal syndrome, or HRS, right? Also, the fluid does not stay in the vasculature, it leaves the vasculature and it goes into the interstitial spaces. So if it goes in interstitial spaces everywhere, that's called edema everywhere, that's called anasarca, right? So anasarca can be a complication or a symptom, but also we can have low albumin states causing fluid to go by gravity into the belly. That's called ascites, right? So that ascites can cause cause a lot of complications in of itself, all right? And then we talk about not being able to mitigate ammonia, so we get hepatic encephalopathy. We can't conjugate bilirubin, right? That's one of the jobs of the liver, so therefore unconjugated bilirubin builds up, and unconjugated happens to be fat soluble, and fat soluble means it goes anywhere at once, right? So it can go anywhere at once, the bloodstream, into the periphery, into the tissues, causing all of our symptoms of elevated bilirubin, right? The T-bili will be elevated, of course, because we can't conjugate it. And sometimes it's so cirrhotic, it's so shut, it's so swollen shut that it can't even get through, right? Or it just does not produce it, and therefore we could get problems. We could get like our UA, our urobilinogen can be low because we're not even producing bile. All right, and what else we got there? So jaundice, hepatic encephalopathy. Remember, we have something the liver produces to make platelets. What's that called? It's called thrombopoietin. All right, so thrombopoietin, or TPO, is produced by the liver, and if we can't produce TPO, we get thrombocytopenia, which is low what? Low platelets, right? And then almost all of our coag factors are made in the liver, except for like factor 8 and von Willebrand's. But either way, 99% of our clotting factors are made in the liver. So if you don't make clotting factors, do we bleed or do we clot more? You bleed more, so you're high risk of coagulopathies, okay? So also that sclerosed and cirrhotic and liver makes it difficult for blood to make its way from the periphery, or from the GI tract, I should say, the GI system into the liver, right? So all of this blood here can't get its way into the central circulation, right? It's because that liver is sclerosed. It's tightened up. It's shut, right? It's closed for business. So it's all sclerosed. It goes from a normal liver to a sclerosed liver. All this fibrotic tissue is preventing the flow of blood through the liver, right? And the majority of blood that flows to the liver is our portal circulation down here. All this blood from our GI tract makes its way into the liver, and if it can't, it's going to back up and make that pressure higher in the portal circulation. That's called portal hypertension. All right, so what else on that? So portal hypertension, have increased pressure in the portal circulation here, right? And then also, I couldn't find out how we'll talk more about portal hypertension, but it actually is going to make itself worse. It thinks it knows how to solve the problem, but it makes it worse. Okay, so a lot of these symptoms from cirrhosis are you have edema, which is anasarca. You have encephalopathy, which is hepatic encephalopathy, HE, right? We got the jaundice, the icteric sclera. We got all this fluid backing up, and this fluid, guess what, can pop into the esophagus, or pop into the gastrum, or pop into the lower GI tract and cause a life-threatening bleed, right? Either a lower GI bleed or an upper GI bleed. And do you think it'd be coffee ground or bright red? Be bright red. So it's either bright red blood per rectum, or what's the other side called? Is it hemoptysis or hematemesis, right? Hematochezia, yes, bright red blood per rectum is also hematochezia, but it would not be melena, it would not be, what's the other one? Coffee ground emesis, right? It's a bright red blood per rectum, it's a bright red blood that's being produced. Okay, and all this blood can back up into the spleen. As we'll find out, when the spleen gets big, it causes problems also. Okay.
Mr. Griffin, someone tried calling me.
Oh, I saw it. That's, we're good. Thank you, though. All right. So with this one here, with am I recording here though? Yeah, I'm still recording over there. All right. So with cirrhosis symptoms, we have, there it goes. So we have all these functions, and these are symptoms that, some are cool. It's like, oh, nice, they got that one. You can be cool on Jeopardy, get the right answer. Other ones are really important, like for hepatic encephalopathy. That's important. For GI bleeding, that's important. For for ascites, anasarca is just a cosmetic deficit, but ascites can start causing problems as well, right? So there are things that are neat, but other things that are actually important that we want to carry over. But there's a lot of symptoms that could be due to liver failing, right? Just something as simple as liver not processing estrogen. So they get small testes, cool, right? They get pulmonary erythema because they can't produce, they got excess estrogen in their body. They got reduced pubic hair. That doesn't affect one thing or another, right? But they do get icteric, right? They do get yellow because they can't conjugate bilirubin, right? So that makes sense, right? Someone that has hepatitis A gets jaundice for obstruction, whereas someone with cirrhosis gets jaundice because they can't deal with it. They can't process it, make it, and conjugate it, right? And there's our biliary symptoms in yellow there, right? Sharpie yellow, highlighter yellow, right? So we got our pruritus, we got our Coca-Cola urine. Those are all signs of an icteric or cirrhotic patient as well, right? They get a lot of hand features for some reason. There's Dupuytren's contracture, there's Terry's nails. Everybody has described something in the last 200 years about cirrhotic patients. And then what's interesting, also they get fetor hepaticus, which is just with poop breath, right? So that is someone who smells lovely, right? They sound like they're dying inside, basically. And so that's a feature that's not going to be tested on, but it's something that is a unique thing that is with liver failure. Okay, so asterixis, which looks like asterisks, right? So asterixis is a sign of hepatic encephalopathy, which is an important complication we have to look out for, right? So asterixis is a hand flap tremor. It's also due to other things building up, like when BUN builds up, when we have CO2 builds up. So it can be other things, but it's important to identify if someone has a huge acidic belly, right, and they're bright yellow. It's probably not that they have the CO2 buildup. It's probably the what building up? Ammonia building up, right? So here's an example of asterixis. So you bring the hand all the way back and it will flap. Right? It's not the patient doing it. It's a response to contraction. All right, what's it called again? Asterixis. All right, so they didn't need the examiner to do it in that case. All right, so important things are the varices. It's a GI bleed that puts you at risk. Sorry, GI bleed is a risk factor, and you can see varices when they do a scope for the patient that's cirrhotic. They do scopes every 3 years or so to make sure they don't have varices that look like they're about to pop. Okay, so also you can see that on the patient itself. It's called caput medusae. So caput being head of medusa. So they have like snake-like appearance on their belly button. All right. Also, they get little spider angiomas on their face and other different areas. And the more of those you have, the more varices they have. So all that fluid backs up and backs up and backs up and makes its way to where it's going to open up things that weren't opened up since literal birth, like the umbilical veins pop open again. Okay. So what else? So ascites is an important side effect we got to know because that leads to complications. It can compress the kidneys and make the kidneys not work good. It could cause a bacterial infection, which we'll talk about. It's called SBP, spontaneous bacterial peritonitis. So that's a complication of ascites. And portal hypertension is usually what's going to kickstart all these problems. All right, so those are signs and symptoms of cirrhosis, and a lot of these are hodgepodge together, and we're going to focus on certain ones of them. So we try to group it together by skin symptoms or hand symptoms. All right, you already know about jaundice symptoms. Now we're going to focus more on like the GI bleed stuff, the hepatic encephalopathy stuff, and the ascites stuff. Okay, so diagnostic tests and complications. So we're going to combine them again because the diagnostic test right here is going to just be a list of diagnostic tests. It's not going to make much sense until we talk about the different complications coming up, right? But because the diagnostic tests you're looking at are to look for the complications, right? So like hepatic encephalopathy, that's a buildup of what? Buildup of ammonia. So we can look at an ammonia level. If that's elevated, they could have hepatic encephalopathy, right? If their AST, ALT is elevated, they could have something that's damage in the kidney, damage in the liver, right? But usually, actually, with stable cirrhosis, the AST, ALT might not be that elevated because they can't make it because their liver cells are dying so much. But T-bili is elevated. Why is T-bili elevated? Because it can't make bili, and you are always making bilirubin, right? Bilirubin comes from RBC breakdown every single day. I think is it 30 trillion? It's like a ridiculous amount of RBCs are being broken down every single day. And that's all that heme has to be converted into bilirubin somehow. So it builds up, and you get your total bili elevates, right? And then albumin will be low or high? Low. Albumin's made in the liver. So your albumin will be low. Therefore, you can't hold fluid inside the vasculature, and it will leak out into the interstitial spaces, causing edema, but also leak out into the belly, causing what? Ascites, right? We'll do a hepatitis panel to see if they have hepatitis that caused their cirrhosis, because we can look to see if there's an active infection, or we can see if they've had it in the past. We do a CT ultrasound to see if there's maybe something cancerous from their cirrhosis, or if there's their liver might even be like sclerosed and literally shrunken, right? Kind of the chronic kidney disease, their organs shrink because they're dying, okay? And then biopsy, they can do a biopsy to assess how much cirrhosis is there. Also do a biopsy to see if there's cancer in a certain suspicious spot. But it's usually done as a last resort. Nowadays we have a cool new ultrasound technique. The ultrasound nerds got out there and they were able to assess the amount of vibration with the sound waves. And the more vibration, the more fibrotic it is. So it's very non-invasive, and they can just quickly do it in the doctor's office. They don't need to get a CT scan or biopsy or bleeding risk or anything. So that was a cool new thing in the last 10 years or so. All right. And we can look at the pancreas and gallbladder as well. That's our last two sections, right? When we have a gallbladder disease, it can make its way up to the liver and cause liver damage. Okay. And then portal hypertension. Again, that's one of the key complications that leads to a lot of other complications that are deadly. Right? If we have portal hypertension, that means we have increased blood flow and increased blood volume inside the portal circulation. And where's the portal circulation? So it's what's going into the liver. It's the entry point into the liver, right? It's from, if you're coming from the stomach, you're absorbing something, you're going into the portal circulation, and now you're in line to get to the liver. If you're coming from the small intestine, large intestine, rectum, all those things are getting reabsorbed into the bloodstream. But first they go to the portal circulation, then the liver, then the bloodstream, the inferior vena cava, right? So all that stuff can back up, and you can get a variceal bleed. You can start bleeding out of those veins that are inside the GI tract. You get a GI bleed, right? If someone's bleeding, our H&H can go down, right? So our hemoglobin hematocrit can go down. EGDs are done every 3 years to assess if they are high-risk spots that might be bleeding. It might even be every 1 year if they bled already. And then splenomegaly, so the spleen will get big, and because of the portal hypertension, all that fluid's backing up. It backs up, yes, into the gastrum, the esophagus, and rectum, but also it could back up into the spleen. The spleen is part of the portal circulation. And that spleen gets big, it actually hangs on to platelets, and it lowers your platelet count even more, which is not helpful. So platelet count being low is extremely important because we do all those fancy calculations to look for like a liver transplant. Platelet count is a big factor in that. That's why it's highlighted. All right. And then hyponatremia. So you have low sodium levels because if you have a low circulating volume through the whole bloodstream, what happens? You have a low circulating volume. It's going back to Med-Surg 1. Low blood pressure equals the baroreceptor is going to fire off, and we get an SNS response, right? And what else happens? You get a RAS response. What's a RAS? The renin-angiotensin-aldosterone system, right? And you get ADH response, right? All three of those fire off, and if all three of those fire off, you got more ADH and more aldosterone. What does ADH do? It absorbs water, right, to restore volume. And what does aldosterone do, which is part of the RAS? It absorbs sodium and water. So if you absorb 1 sodium and 2 waters, Are we going to have a high sodium level or a low sodium level? Low. So that's why these guys are hyponatremic. And you can actually tell if someone is really, really advanced disease if their sodium is like 126 at baseline. At first, if someone has 132 at baseline, versus 126 in cirrhosis is much worse off, right? Same thing with T-bili. The T-bili is like 12. They're much worse if someone has T-bili of 24, right? They're much more advanced cirrhosis and much more likelihood of dying, okay? So what else? Because this is an irreversible process unless they get a liver transplant. All right, what else? Hepatorenal syndrome. So we have this low circulated volume through our whole bloodstream. Therefore, we're going to have a low circulated volume to our kidneys. Our kidneys get upset. Your kidneys get upset. You look at their function gets poor. And how you assess kidney function is our creatinine, right? So it's greater than 1.3 creatinine, or we got a 0.3 elevation, right? A 50% increase. All these things, our creatinine is going up, basically. That's bad, and that's a sign of hepatorenal syndrome. Right? Hepatopulmonary syndrome, we're not going to get too much into, but ascites, right? That's a result of portal hypertension also, but it's also a result of albumin being poor. And we can measure albumin levels. What's a normal albumin level? The same as potassium, basically. So it's like 2.5 to 5, 2.5 to 4.5. So it's less than 2.5. That's not good. That's a sign your liver is not working, not producing. And it's actually an important risk factor that would get them on a transplant list. So platelet count, albumin, and platelet count and INR are important things to get you people on transplant lists, right? And then SBP we mentioned, spontaneous bacterial peritonitis. You're at risk for that when you have ascites, and we'll talk about how that happens. But if someone has an infection, you expect them to be febrile, have an SS response, and have a white count, which is part of a surge response. Right? A surge is a systemic inflammatory response, right? The whole inflammatory system is firing off. Yes, you get a flu-like symptoms, you don't feel good, but also your SNS fires off. So you got the fever, and you have tachycardia, tachypnea, etc. Okay, and coagulopathy we touched on, right? Coagulopathic, platelet counts down because why? They're not producing TPO, and also we'll find out the spleen is actually holding on to platelets like it shouldn't. And the INR is high, the bleeding time is high. Why? Why do patients with liver failure have higher bleeding risk? They're not producing platelets, but also they're not producing coagulation factors to even make a clot, right? To make a clot, you need coag factors and you need platelets, right? And you also need fibrinogen, which makes the fibrin, which is the mesh for the clot, right? So we have decreased fibrinogen, which ironically is made in the liver, right? It's one of its 500 functions. So you can't make clots good, therefore you have much higher bleeding risk, right? And hepatocellular carcinoma, so they're high risk for cirrhosis progressing to liver cancer, right? And we measure that with alpha fetoprotein, AFP. And they'll do a MELD score or a transplant list score to see if they are in need of a transplant, right? And then all the cirrhosis symptoms can lead to end-stage liver disease, which is basically, yes, it could progress to cancer, but they are chronically in and out of the hospital multiple times, and it's a downward spiral. So I think that red line is mortality, right? Liver failure, acute decompensation. So they decompensate over like 3 to 5 years. So all these complications we've been talking about, all these things are going to lead to ultimately a patient that will have a really high mortality and can die from their complications. Okay, so the bottom left here you can see a cirrhotic liver. It just looks like a stone, right? It's all sclerosed and dead. Okay, so coagulopathy. So you have a liver that's not making platelets. So cirrhotic liver, it's not producing TPO, or sorry, decreased TPO here. Therefore, we have TPO works on the platelet factory. Where's the platelet factory at? Nope. Liver makes the TPO to go to the platelet factory to make more platelets. That's the bone marrow. The bone marrow is where we make all of your blood cells, your white blood cells, your RBCs, and your platelets, right? The cell is called a megakaryocyte, and it sheds off platelets, right? So if we have no TPO, we're not going to make platelets. Okay. Also, all that increased fluid in the portal circulation that's trying to make its way up to the liver, right? All this fluid is trying to make its way up in the liver, right? All that's trying to get up there. and then it can't. So now it's all backed up like a ride at Disneyland, right? So now the line gets bigger and bigger and bigger. So you can see the black dotted line there is actually a normal size spleen, and it gets splenomegalich. It gets a huge spleen, right? So you get splenomegaly. Do you have hepatomegaly? No, you have a tiny e, right? You get a tiny cirrhotic liver, right? But a big spleen. Okay, and when it gets big like that, it says, hey, there's now I have extra space to store things, right? It's like buying the deluxe package at 1-800-storage, right? Now you can put all kinds of things in there. And the spleen says, well, you know, it's perfect, platelets. So it puts a whole bunch of platelets in there, right? Because the whole purpose of a spleen is what? What does a spleen do? So it's a big lymph node. So it's like a Brita filter for our blood, and it will filter out and be the first thing to see an infection. But also, what else is the spleen for? Like trauma-wise, it's a storage for RBCs and platelets, so that when you are bleeding and you get a huge injury, it squeezes. As a muscular capsule, it squeezes a whole bunch of RBCs and platelets just in case you're bleeding, so that you can restore hemostasis. So it thinks that it's saving it for a rainy day, but it's actually causing more problems because it's storing platelets away that you need just for everyday activities. You get bruising, and you get all kinds of other bad things when you have a low platelet count, right? Also, cirrhosis itself is an inflammatory condition, and we'll learn after the test, when we talk about sepsis, about infections and sepsis that causes consumption of platelets. So that's another reason why the platelet count is low, right? So poor nutritional intake, these guys do not like to eat. Their whole portal circulation is swollen. They have anorexia. What is anorexia? Poor appetite, right? So all this fluid is all backed up into the gut. Just like a CHF patient has all that fluid back to the gut, they have poor intake, right? All that fluid's backed up, and they're not going to want to intake. If they don't intake good things, they don't have vitamin K, and vitamin K is needed for clotting, right? So they get coagulopathy. They have coagulopathy because of that, right? They don't have the clotting factors being made in the first place from the liver. They have poor intake, and they have TPO not being made. You have the spleen getting huge. All these things are working against the patient with liver cirrhosis, right? The thing is, in the early stages, though, you think they're a high bleeding risk, but actually they are going to upregulate things, and they actually need a DVT prophylaxis. Because, oh no, their INR is 2.2. They don't need to have any kind of anticoagulation. They still do. Usually we are going to keep giving it until the platelet count is super low. So if your platelet count is low or hemoglobin is low, that's when we would hold it. They're still at risk for, again, they have an inflammatory process at all times, and they're going to cause clotting to happen and cause more problems. The INR is important to recognize that it is not accurate. So you have an INR 2.2, that's different than INR 2.2 in someone that's healthy. With someone with liver failure, their INR 2.2, they have other things they've done to compensate, right? Oftentimes they'll give them FFP, right? FFP will fix an INR. Right? FFP is just plasma. Plasma has coag factors. It has things in it that are going to make your INR, your bleeding time, get reduced, right? But as we find out, if we give FFP, what's going to happen? All that fluid, that 400 cc's of fluid, 300 cc's of fluid is going to be instilled through a vein, right? It's going to make its way to the heart, and the heart is going to then pump that FFP to the portal circulation, and now you've just put more fluid inside the portal circulation. You've increased portal hypertension, you've increased the risk of bleeding, you've increased the risk of thrombocytopenia, you've increased all these worse off complications, okay? So FFP should not be given. If we need to give it, if we need to correct a coagulopathy, we would give platelets if we need to. Also, we could give TPO analogs. So it's like PO, TPO, or it's IV or sub-Q TPO, right? But those are not reachable by the normal population as well. It's $500 per pill, right? You have to take that every single day, $500 per pill. That's like $180,000 that you have to pay per year, which is completely out of reach for most people. Okay, that is an option once that becomes more available. And medications do become available after 10 years because the FDA puts a patent on it, or the drug company puts a patent on it once it gets FDA approved, and they have 10 years to make a new medication so they can charge extra for the new medication. But the old medication then can now go to Walmart and everybody can get it then. Okay, and then you have insurance that covers it or not covers it. It's a whole thing. Okay, all right, so that's cirrhosis and coagulopathy. So what is this? Oh, this is the vitamin K. If you didn't know about vitamin K, It's usually in a glass vial. When you pull something from a glass vial, what do you need? You need a filter needle.
So here's a cool trick about opening an ampule. Of course, use an alcohol pad and snap it away from you, but you can turn it upside down without a drop falling out due to surface tension and with the air pressure being greater than the pressure on the other side of the opening, so you can drop your medication without the liquid flowing out, just like this.
Okay, so there's a feature of vitamin K ampules.